Our next topic will be ectopic pregnancy. When we say ectopic pregnancy, it is an extrauterine pregnancy. When we say it is an extrauterine pregnancy, it is a pregnancy outside the uterus. Okay, it is a pregnancy outside the uterus. Why? Because it should be the uterus that is the site for implantation. So let me just repeat that. Site for implantation. It should be the uterus that is the site for implantation, and it should not be anywhere from the reproductive tract. Okay, so that is ectopic pregnancy. Any pregnancy outside the uterus. Okay, what are the predisposing factors? We have here number one, the fallopian tube are narrowing. When we say narrowing, okay, it could be that the fallopian tube is not enough. The space of the fallopian tube is not enough for the blastomere to go out and implant itself to the uterus. Or we have here PID. These are your pelvic inflammatory disease. Okay, these are your pelvic inflammatory disease. Okay, this could be coming from multiple sexual partners, and we also have here salpingitis. When we say salpingitis, it is the inflammation, okay, of the fallopian tube, and when we say endometriosis, okay, it is the proliferation of the endometrium to the other parts of the body, okay, to where, to your intestines, to your ligaments, and to your ovaries. Okay, so we have here, when we say endometriosis, it is the proliferation of the endometrium to the other parts of the body, such as in your intestines, ligaments, and in your ovaries. But take note that endometritis is different from endometriosis, because endometritis talks about inflammation of the endometrium. So again, endometriosis is the proliferation of the endometrium to the other parts of the body. Next is we have here prior tubal pregnancy. So a history of ectopic pregnancy could predispose you to have another ectopic pregnancy again. A history of ectopic pregnancy could predispose you to have another ectopic pregnancy. Sorry, for your prior tubal surgery, meaning maybe you had a salpingotomy or you had other surgeries done before you got pregnant. So that could be a factor for you to have ectopic pregnancy. When we say puerperal and postpartal sepsis, meaning you had infections that might be causing uh, the irregularities of the fallopian tube, or congenital abnormalities of the fallopian tube, that there is an underlying anatomical problem of your fallopian tube before you get pregnant, and you have here adhesions. Okay, when you say adhesions, they might stick to each other. Spasms, okay, the spasms, the peristaltic movements of your intestines, or sorry, the peristaltic movements of your fallopian tube is not that good, and maybe the presence of tumors. Okay, and it has been written in history that the use of IUD, or your intrauterine device, okay, is one of the predisposing factors to ectopic pregnancy. Actually, in the word exam, if they would ask you what family planning method could lead to ectopic pregnancy, the answer is IUD. And if you are above 40 years of age, again, above or below the reproductive age, is a predisposition to any of the complications of pregnancy. We have here the types, right? We have the tubal, so anything that is now implanted in your tube, that it's tubal. Maybe it's here in the isthmus again, right? Or here in the ampulla, or here in the infundibulum. Why? Because the tube should not be the site for implantation, but it is the site for fertilization. So It could also be implanted here in the interstitial or the intramural, or it could be cervical here in the cervix. Sometimes it's because of in vitro fertilization. Abdominal, when you say abdominal, it is coming from a ruptured ovary that usually it was an ovarian, but when the ovary ruptured, okay, the baby just go down in the abdomen and it becomes abdominal. And here we have peritoneal. Okay, so again, the site for fertilization is the tube, but it should not be the site for implantation. And another thing is we have to remember that there is also what we call as heterotypic ectopic pregnancy. Okay, heterotypic ectopic pregnancy, and this is sometimes written in other books. We have heterotypic ectopic pregnancy. When we say heterotypic ectopic pregnancy, there is a tubal pregnancy or an ectopic pregnancy, and there is also a normal pregnancy. So what will they do is to save the normal pregnancy, then eliminate the ectopic pregnancy for that matter. Of course, it's the same, but if you're pregnant, there will be a brief amenorrhea. And this brief amenorrhea will be telling you that you are pregnant and you are having an abnormal menstruation. Right? So what are the early signs of ectopic pregnancy? Sudden, acute, low abdominal pain. Why is it low abdominal pain? Because it's in the fallopian tube. There is also nausea and vomiting since you have your HCG, you're pregnant. Okay. There is your colon sign or the bluish discoloration of your umbilicus. Okay, here. This is the colon sign. Okay. Rectal pressure. Okay. I'm sorry for that when it's cut there. Okay, there is also rectal pressure, maybe because secondary to maybe because it is secondary to the rupture of the ectopic pregnancy. And there is also a positive pregnancy test, and there is a sharp localized pain when the cervix is touched, and signs of shock or circulatory collapse if the ectopic pregnancy is already ruptured, because we also have ruptured and unruptured ectopic pregnancy. What are your findings? There could be low hemoglobin or hematocrit that is indicative of internal bleeding. That could be also visualized via the colon sign, or internal bleeding that low hemoglobin and hematocrit that is indicative of internal bleeding. That could be presented by the colon sign, or there is low human chorionic gonadotropin and elevated WBC. Okay. What are the diagnoses? Of course, you have to know the clinical signs and symptoms. Number one is the knife-like stabbing pain. When we say knife-like stabbing pain, for example, if it will be the right fallopian tube that is affected, then you will have stabbing pain on your right shoulder down. Okay, and then you will have to have ultrasound to locate where is the ectopic pregnancy, HCG monitoring. Okay, for us to know if for example, if we have removed the ectopic pregnancy, okay, we have to be very sure that HCG is 0. Or laparoscopy, should there be what abdominal ectopic pregnancy? And you also have here your hemogram. So what is hemogram? What is hemogram, guys? Okay, so when you say hemogram, it is a complete blood count. Okay, it is a complete blood count. It is a CBC, meaning you have to measure. Okay, you have to measure all the blood constituents. You have to have your CBC and of course your ESR or your erythrocyte. What is ESR again? Erythrocyte sedimentation rate. Okay, so you have to have your CBC. Okay. Next. For the treatment, of course, number one will be self-injectomy. We wanted to remove the fallopian tube because whenever, for example, if you have done self-ingotomy, right, if you just open the fallopian tube, it will leave a scar. and the scar could predispose the woman to have another ectopic pregnancy. Okay, the scar could predispose the woman to have another ectopic pregnancy. And if, for example, there is already internal bleeding and colon sign, you have to manage shock. You have to give antibiotics for the possibility that there are infection for elevated WBCs. Okay, and of course, the drug of choice is methotrexate. Okay. Okay, the drug of choice here that you will have to use is methotrexate. Methotrexate is actually a drug of choice for HMO. But then again, methotrexate is also used in ectopic pregnancy to dissolve an unruptured ectopic pregnancy. So if it's ruptured, we'll have to do salpingectomy. If it's not yet ruptured, then we will have to save the consistency of the fallopian tube. So we are giving methotrexate. What are the contraindications? So do not give methotrexate if the tube is already ruptured, because we will have to do salpingectomy. If there is an intrauterine pregnancy, as it might also dissolve the intrauterine pregnancy, such as in your heterotypic ectopic pregnancy, and if the person or the client is immunodeficient, or if the client is breastfeeding, or if the client has peptic ulcer, or if the client has hepatic, renal, or hematologic dysfunction. So these are the contraindications of your methotrexate in general. Again, we are only giving methotrexate if the tube is not yet ruptured. If the tube is ruptured, then we will have to do a salpingectomy. Complications. As I've mentioned, the ruptured ectopic pregnancy could lead to shock or hemorrhage. And it could lead to infection. That is why we are also preparing for antibiotics, and antibiotics is also included in our treatment implementation. And RH sensitization, meaning you have to know if there is an RH incompatibility. Later on, we will discuss about RH incompatibility, wherein the mother is RH negative and the baby is RH positive. Okay. For our responsibilities as nurses, we have to carry out an ongoing assessment for shock, meaning carrying out of an ongoing assessment, meaning we don't leave the patient. We have to monitor the patient for possibility of shock. And then, of course, we have to implement shock treatment promptly should there be the ruptured ectopic pregnancy. And if there is hypotension, then we have to position the patient anteposition, giving of your 5% dextrose in lactated Ringer solution, or your D5 LRS would replace the fluid loss, okay? Or would help the patient, okay, for blood loss. You also have to monitor the vital signs for bleeding. When you say the bleeding, you have to monitor the bleeding, how extensive the bleeding is, and of course the INO, the input and the output of the patient will give you an assessment or a data for your assessment if there is already shock or internal bleeding, and provide physical and psychological support. The psychological support here is for you to be able to discuss to the mother that the pregnancy will not continue anymore, and that some interventions will be done. That is depending on the case of the patient, if it's a ruptured ectopic pregnancy or an unruptured ectopic pregnancy. So you really have to explain to them the pros and cons of the interventions. So that is ectopic pregnancy, right? Any pregnancy that is outside the uterus. Next topic is hyperemesis gravidarum. When we say hyperemesis gravidarum, it is pernicious, okay? Pernicious or pernicious vomiting. Okay, when we say pernicious vomiting, it is vomiting about because normally we have the morning sickness. Okay, because normally we have the morning sickness. When we say morning sickness, it is only normal for the first 3 months of pregnancy. Okay, morning sickness is only normal for the first 3 months of pregnancy, or the first 12 weeks. And if there is an excessive vomiting, that is hyper excessive, emesis is vomiting, and gravidarum is during pregnancy. So it is excessive vomiting during pregnancy. It is excessive vomiting during pregnancy. So what will we do here? Okay, since there is hyperemesis gravidarum, it could lead to what? Dehydration. And we don't want the patient to be dehydrated. Why we don't want the patient to be dehydrated, guys? Remember, okay, if you are dehydrated, your posterior pituitary gland will stimulate the production of your antidiuretic hormone. And in response to that, your body will produce oxytocin, okay? It will produce oxytocin. So again, number one is you have to avoid dehydration. Why? Your posterior pituitary gland will what? Produce antidiuretic hormone, and your body will produce oxytocin. And of course, later on, you will have your contraction. And that could aggravate the condition because the patient is not yet in labor or the patient is not yet term. Okay, so it could also lead to ketonuria and significant weight loss. And that is starting with dehydration. Next is the cause of hyperemesis gravidarum is still unknown, but we have here predisposing factors like your increased thyroid function because pregnancy is a hormone related phenomenon. And we have here human chorionic gonadotropin. Here it could be because of an H hormone, okay, that is present. Another one is Helicobacter pylori. Okay, your Helicobacter pylori or pylori, however you pronounce it, is new because before the predisposing factors of hyperemesis gravidarum is increased thyroid function, HCG, and psychological stress. But now psychological stress is now being eliminated and Helicobacter pylori is included in the predisposing factors. Again, the cause is unknown. It's idiopathic. How would you assess? You have to know how late into the day did the nausea last? Okay, how many times did they vomit and how much? And what was the total amount of food they were able to eat? So you have to assess how this nausea last if it's the whole day. Okay, how many times did they vomit and how much? Okay, you have to know um their intake and output, their intake, of course, and the output or the vomitus, and you have to know if the patient is able to eat. Why? Because the patient is pregnant, there is a baby inside. You really have to know if the patient is able to eat or not. Next is therapeutic management. Of course, you have to hospitalize the patient. Why? Hospitalization is a must for hyperemesis gravidarum patient. If you will be, for instance, if you will be placing a patient with hypertensive disorders in pregnancy in bed 1 for you to be able to assess if the preeclampsia will become an or will become eclampsia. For this hyperemesis gravidarum patient, you will have to what? You will have to position or you will have to place the mother away from the nurse's station. That is a common board exam question that you will have to put the mother away from the nurse's station because this mothers doesn't want what? Um, extra disturbance on them. So hospitalization is a must for us to be able to replace whatever is lost. And the patient should be NPO for 24 hours for the first 24 hours. As long as the patient is vomiting, we are not to give anything, okay? After the patient is, for example, if the patient is no longer vomiting, what will we have to do is we start with small frequent feedings, and of course, do not forget that it should be eating crackers before going out of bed, or you have to let the patient eat crackers before arising in the morning. So you have to let the patient eat crackers before arising in the morning or before the patient is getting out of bed, okay? Or before the patient gets out of bed. You also have to give an IV of 3,000 D5-LRS plus vitamin B1. For this one is you really have to give this one because of the fluid loss, and you have to give your metoclopramide, okay? You have to help the patient to stop from vomiting, and as long as the patient is not vomiting anymore, you could give your oats or crackers or cereal. And if it's needed, you will have to give your total parenteral nutrition because the baby is needing nutrition also. Okay, so if the patient will not be well at that moment, reduce the intake of caffeine and artificial sweeteners because this might aggravate vomiting, or it might just give the patient a feeling of contentment or fullness or anything, but it is not that nutritious, okay? Because caffeine will just make you feel good, but then again, it will not be nutritious and it will not be helpful for the baby. And remind them to take to take vitamins. But according to book, you are not allowed to take your ferrous sulfate. You are not allowed to take your ferrous sulfate. Why you are not allowed to take your ferrous sulfate? Because it will give you what GI upset, and it will what further vomiting. It will further vomiting. Okay, it will further vomiting. So again, perosulfate should not be given because it will give you what GI upset, and it will just further vomiting. Okay. So again, give crackers before arising in the morning or before getting out of bed if the patient is no longer vomiting. So that is your hyperemesis gravidarum. Before we proceed to the other topics, okay, your hyperemesis gravidarum, you could also give antihistamine, anti-vertigo, and that is three sets of medications: antihistamine, anti-vertigo, and antiemetic. Okay, you have to give antiemetic, antihistamine, and anti-vertigo. If the board exam will ask you what are the medications given to patients with hyperemesis gravidarum, you could give antihistamines, anti-vertigo, and your antiemetic. Okay, let me just write that. Okay, so you will have to give your antihistamine, anti-vertigo, and antiemetics. Okay. Next is your placenta previa. When we say placenta previa, it is an implantation of the placenta in the lower part of your uterus. It should be, you see the normal condition, it should be here high, but for placenta previa, it's down there. It is the most, okay, in the board exam, they will ask you, it is the most common cause, okay, of bleeding in the third trimester. It is the most common cause of bleeding in the third trimester. It is actually 1:150 of patients. So what are the risk factors? Multiparity, when the uterus is overused, of course, the placenta will look for another part of the uterus to implant itself. Decreased vascularity in the upper segment if the mother is multiparous. Okay, it is repeatedly, if the placenta is repeatedly implanted here up, then the placenta will look for another location to implant. And if another again and again and again, if your age is above the reproductive age, then you are prone again to any of the complications of pregnancy. And multiple pregnancy, if the placenta is looking for a better implantation site for the two or more fetuses. We have here the types of placenta previa. Okay, for a normal placenta, it should be here up. Low implantation is here down. Okay, if it's partial, it totally covers or it covers the half of the birth canal, and if it's a total placenta previa, then it covers the birth canal. So for low lying, this is a low implantation, meaning for a low lying, it does not touch the internal os. It is a low lying placenta, wherein a low lying placenta, they are allowed to deliver via NST, provided that we have a double setup, meaning you have to set up the delivery room and the operating room as well, for the possibility that the patient might suffer from bleeding. And for partial placenta previa, okay, it covers half of the uterine of the cervix, I should say. And for total placenta previa, it covers the whole or the totality of the birth canal. And when we also have what we call as okay. So if we have low lying, we have a partial, we also have marginal. Marginal, if it's implanted in the margin of the internal os. If it's implanted in the, if this is low lying, this is marginal, this is partial, and this is total. Okay, so this is your marginal, this is your partial, and this is your low lying. So it is not included in the picture. What will you do, or what will you assess? What is really a problem here is for placenta previa, it is painless. So when the patient is never or is not in pain. Okay, if the patient is not in pain, usually they will not seek for medical attention. So sometimes we characterize, or we how do we assess the patient? We will assess the patient by, like, the patient is lying in a pool of blood, literally. Okay, the patient is soaked with blood here from the head down, but the patient doesn't feel anything. That's why they will not seek for medical attention. So that is really sometimes the problem in placenta previa. Okay, I'm trying to think of that term, but I really cannot think of it. So it's a fresh bright red. Why? It is very external. It's coming down here. And it happens usually in the third trimester. So that is why it is the most common cause of bleeding in the third trimester. Okay, it is the most common cause of bleeding in the third trimester. Again, it is the most common cause of bleeding in the third trimester. And here, uterus is soft or flaccid. Okay, it may be having intermittent hardening or contractions. There is also intermittent pain. The bleeding is there. That might predispose the patient to have what? Shock. And you have to diagnose by ultrasound if what type of placenta previa the patient is having. If it's a low-lying placenta, marginal placenta previa, partial placenta previa, or total placenta previa. What is the treatment? Watchful waiting, meaning you have to save the baby if you still can. That is what we call conservative management. If you can still do something about it, then you have to save the baby. Right? If the mother is not in labor, or if there is no contraction, okay? If the mother is not in labor or there is no contraction, if the fetus is premature, stable, and not in distress, then you have to save the baby kasi you see it's premature. Okay? And if the bleeding is not severe, it's not causing a deadly shock to the mother, you could do amniotomy. Okay, if for example that the baby is already mature, if the baby is okay for delivery, you will have to do amniotomy. You will have to deliver the baby. Why? To prevent shock from the mother. So again, if the baby is mature, then we could do amniotomy. What is amniotomy? Again, you have to what? To rupture the amniotic sac. Double set up, meaning you have to prepare the operating room and the delivery room. Again, for placenta previa, it is a bright red bleeding in the third trimester, and it is painless. Okay, again, you have to have double set up for in the case of low-lying placenta previa, because in low-lying placenta previa, the patient might be allowed to have normal spontaneous vaginal delivery. But in case if the patient will have bleeding inside the operating room, then preferably you will have to have the double set up, so we're ready for a cesarean section. And in any bleeding disorder in pregnancy, we are not allowed to do an IE. Okay, we're not allowed to do an IE. For the complications, we have here hemorrhage because of the bleeding, prematurity if in case we have to deliver the baby to save the mother, obstruction of the birth canal that will allow us to that will prevent us from having normal spontaneous delivery and will allow us to have cesarean section. What will you do? Bed rest. Actually, in the book, it is bed rest without bathroom privileges. Okay. Actually, in the book, it is bed rest without bathroom privileges. Okay. Bed rest without bathroom privileges, because we don't want the patient to move. Why? The more the patient is moving, the more the bleeding will the more the bleeding that the patient will have. Do not perform an IE. Who is allowed to do an IE? If there is anybody else in the area allowed to do the IE, it should be the doctor, okay, but not the nurse. Careful assessment of shock, and of course, the situation of the baby. Prepare the patient for an ultrasound if delivery is not yet happening. Okay, institute shock measures. You have to institute shock measures, meaning you have to prepare for a shock. Provide psychological and physical comfort if, for example, there is a premature delivery, or there is non-reassuring fetal heart rate pattern, or possibility of harming the life of the baby and the mother. And prepare for conservative management, meaning for conservative management, if we could save the baby if we could wait for the baby to become mature, and that is the best thing that we could do. That is what we call as conservative management. Another bleeding disorder is your abruptio placenta. It is the premature separation of the placenta from the point of implantation before the birth of the baby. Let me repeat. It is the premature separation of the placenta from the point of implantation before the birth of the baby. We call it as your accidental hemorrhage or your ablation placenta. And it is the second leading cause of bleeding in the third trimester. And it is 1:300 pregnancies. So this is not common. But in the book of Lang, it is now the most outstanding cause of perinatal mortality. Okay. It is now, okay, the outstanding cause, okay, of perinatal mortality. Okay, it is now the cause of what? Perinatal mortality, or the death of the baby and the mother. What are the predisposing factors? It is almost the same as your Previa, that it could be because of maternal hypertension, because of vasoconstriction, the PIH because of the pregnancy-induced hypertension, because of the presence of hypertension, edema, and proteinuria, and renal disease, okay, and renal disease. Sudden uterine decompression, if, of course, ang sudden uterine decompression kasi if in multiple pregnancy, you tried to deliver the lowermost twin in an NSD, or you might have a preterm labor. Preterm labor or preterm delivery could give you, okay, a sudden uterine decompression or in a polyhydramnios. Another one is advancing age, multiparity because the uterus is overused, and short umbilical cord. Why the short umbilical cord? If the baby is moving, okay, if the baby is moving, then the baby is pulling the placenta, okay, or trauma to the implantation of the placenta and the fibrin defects. Okay? That the fibrin defects is new. It was not explained very well by the book how it would cause your abruptio placenta. Okay, for the types we have here, the concealed. Before we only have two types, but now we have three. The concealed is the one that is what we call as your covert. The placenta separates first from the center. Okay, the bleeding of the concealed is darker red. Why? Because it is separating first from the center. The mixed, it could be covert or overt. Revealed is your overt. Okay, overt abruptio placenta when the placenta separates first from the edge. Okay? And the bleeding might be brighter than the of that concealed. Okay, so again, we have three types. We have the concealed, mixed, or revealed. Before it was covert and overt only, but now we have the mixed. Next is types of abruptio placenta, type 1, type 2, and type 3. When we say it is the concealed, covert, or central type, there is no external bleeding. So the blood is darker, and sometimes the signs of shock are not proportional to the amount of external bleeding because it's covert or concealed. The bleeding is in the center, right? From the placenta or from where the placenta separated itself from the uterine endometrium. Another is type 2, your marginal overt or obvious or external bleeding type. So the placenta separates first from the margin or the edge. It might be complete or incomplete, but it is of external bleeding. Usually it is old blood or darker red. So sometimes, again, we have to repeat this one. For the concealed, it is darker than of the type 2. And for type 3, some of the part of the blood collects inside, it is concealed, and some part are expelled out. For the findings, you have to note the painful vaginal bleeding. So this is a painful bleeding in the third trimester. You will have a rigid word-like abdomen, and it's painful. It is just like a normal labor. And there is also enlarged uterus because of concealed bleeding, probably in a covert placenta previa or covert abruptio placenta. Okay, you have your tetanic uterine contractions when you say tetanic uterine contractions. These are contractions that never stops and it could lead to uterine rupture. For the clinical diagnosis, you have to note the signs and symptoms. You have to note if it's painful or painless. You have to note the characteristic of the bleeding, if it's bright or dark. You have to note also retroplacental bleeding or bleeding in between the placenta and the endometrium, and clotting studies for disseminated intravascular coagulation. Actually, the disseminated intravascular coagulation is one of the most unwanted complication of abruptio placenta. These are the complications. That is why it is what we call as your number one cause of perinatal mortality. Because of shock, you could have covalular uterus from internal bleeding. You could have your disseminated intravascular coagulation. Later on, we'll have a separate discussion for this one. For CVA, you will have hypofibrogeninemia and renal failure, infection, prematurity, intrauterine fetal death, and that is because you primarily had uteroplacental insufficiency. And nursing implementation, bed rest, preferably no bathroom privileges. You have to monitor the vital signs, FHT, labor onset and progress. You have to save the baby if you still can. The INO will give you an idea of the level of the shock of the patient, and the patient might suffer from oliguria or anuria or the absence of urine. Uterine pain that might mimic the pain of uterine contractions, bleeding that would lead to shock, and you have to administer your IV plasma and blood for shock management, and prepare for emergency cesarean section if it's inevitable, and watch out for covalular uterus and disseminated intravascular coagulation that might cause the death of the baby. So that is our lesson for week 7, 8, okay, and 9. And we'll have more next time. Thank you.